Okay, so this is chapter 43, nursing care of male patients with genitourinary disorders. For ATI, this is chapters 63 and 64. For your regular med-surg text, this starts on page 1004. And since we already did a review of anatomy in the last lecture, I'm not going to go over that again in detail again in this lecture. Instead, we'll start discussing specific disorders and signs and symptoms, and then, of course, nursing diagnosis, regular diagnosis, therapeutic interventions of some of these types of disorders. First, we're going to prostate disorders, and for this beginning part, we'll be talking about, or in this particular lecture, we'll be talking about prostatitis, benign prostatic hyperplasia, or BPH, as it's called pretty commonly, and then we'll talk about prostate cancer as well. An inflammation of the prostate gland, which can happen anytime after puberty. It can be either an acute type of problem or a chronic problem. There are 4 different types of prostatitis: acute bacterial or chronic bacterial, and then there's a chronic prostatitis or chronic pelvic pain syndrome, and then there's an asymptomatic type of prostatitis as well, which is an inflammatory prostatitis. Common bacteria that cause prostatitis are E. coli and Staphylococcus aureus. It can also be caused by sexually transmitted infections or urinary tract infections, urethral traumas, any type of bacteria in the blood or lymph systems that supply this gland. So signs and symptoms of prostatitis are pain or urgency, feeling like you have to go to the bathroom like right now. Frequency, meaning you're going most often or more often. Dysuria or pain with urination. Because it has an element of inflammation to the prostate, it can also cause urinary retention. And then if it is of infectious process, maybe fevers or chills. Prevention is to regularly and completely empty the bladder, which will prevent urinary tract infections. Also avoiding high-risk sexual behaviors that would cause or give the man a higher risk for sexually transmitted infections, and also to avoid excess alcohol, as this can be irritating to the bladder. Complications are urinary retention from the swelling of the prostate. May also cause temporary problems with erection, and it can also cause other infections such as prostatic abscesses, epididymitis, or prostatic calculi or stones. Diagnosis can be through a digital rectal exam or DRE. When this is done, it may reveal a warm or irregular, swollen, very painful type of prostate. Urine cultures can be obtained. These would be positive for bacteria. There also can be expressed prostate secretions that are sent for analysis, and this is where the prostate gland is massaged in order to collect the prostate secretions. And usually these tests will be positive for bacteria and a large or a larger high amount of white blood cells. They can also do some cystology or cystoscopy, can also be done in order to collect cells and to look at how things are in there. Some that can be used are antibiotic therapy. The recommended treatment plan is to be on Bactrim for 30 days. That's the preferred treatment. But there are other treatments or antibiotics that can be used, like Keflex or Another one would be Levaquin. Anti-inflammatory agents, which will help with swelling and pain. Stool softeners and sitz baths will help with not causing further trauma. Also, because they're so closely related in anatomy, the passage of a hard stool can cause increasing pain. Prosthetic massage can be used to, again, get secretions out and decrease inflammation. Dietary changes may need to happen. Avoiding alcohol and spicy foods. Again, these are bladder irritants. The patient should also avoid taking alpha-adrenergic agonist medications, which can cause urinary retention. And then surgery might be indicated if it's severe or it's not being treated appropriately or not being treated effectively through other means. So nursing diagnoses that you'll see for prostatitis are urinary retention, and that's related to obstruction, risk for ineffective health management, and that's related to a knowledge deficit about the cause or treatments and prevention for prostatitis. Certainly acute pain related to the swelling and irritation of the prostate gland, and anxiety around pain or other sexual concerns that the patient might have. So BPH, this is a slow increase in the number of cells, and it's an enlargement of the prostate gland. It's a normal process in older men, and it affects about 75% of men that are older than 70. Signs and symptoms include urinary retention, dribbling, nocturia, dysuria, and urgency. Nocturia is where they have to go frequently at night. BPH is non-malignant growth of the prostate that eventually causes problems with urinary obstruction. So for prevention, there's really no proven method for prevention, but one treatment that's currently being researched is the use of saw palmetto, which is a herbal supplement. Some of the complications that are seen with BPH are hydronephrosis, and this is from the urine backing up into the kidneys. You can also see renal insufficiency, urosepsis. There can also be damage to the bladder walls, which can cause bladder dysfunction, and then that leads to recurrent UTIs or stones. And it can eventually lead to the complete inability to urinate. And at that point, it's very important that they get to the emergency department. That is an emergency, and they will need to have a catheter placed one way or another in order to empty the bladder. The diagnosis of BPH is generally done through digital rectal exam. There are other types of tests that can be done to check out kidney function, like BUN and creatinine. There's also a blood draw that can be done for prostatic specific antigen, or PSA. Urodynamic flow studies, which can show the decrease in urine flow rate. They can also do some types of radiological diagnostics, like a transrectal ultrasound or cystoscopy. Sorry, I can't say that very well. And these can reveal or may reveal structural abnormalities that may be causing the problem. So therapeutic interventions that you might see. Certainly there can be symptomatic types of control where they're putting catheters in to help to empty the bladder, fluids, antibiotics to treat any types of infections that might go on. If there are no symptoms or minimal symptoms, they will do watching and waiting. They may also give alpha-adrenergic antagonists like Flomax, which will relax the smooth muscles and increase flow. Hormone blockers like Proscar or Avodart. And then they can do other types of therapies like transurethral microwave therapy, which involves applying heat to the gland to inhibit growth, or transurethral needle ablations, where radio waves are used to destroy part of the gland. They may also surgically place stents to open up the pathway so that the urine can flow more freely. One type of surgery that they do is a transurethral resection of the prostate to remove tissue and reopen the prostate, and this is called TURP. And there's a scope that is inserted through the urethra down the penis, and then the overgrown tissue is chipped away. Or they could end up with prostatectomy. This can be usually seen for treatment of prostate cancer, but certainly if the prostate gets too large and the chipping or other surgeries aren't working, they certainly can remove it altogether. This can be accomplished through multiple different modalities. They can do it in an open fashion where they actually make an incision in the lower abdomen, or make an incision between the scrotum and anus. Although this procedure, the one where the incision is done between the scrotum and anus, is rarely done because of the increased risk of problems with incontinence. And then they also can be done using laparoscopy. So there's lots of different ways that this surgery can be accomplished. So preoperative nursing diagnosis that you'll see for prostate surgery are impaired urinary elimination or knowledge deficit about the actual disease or treatments or those kind of things. So post-operative nursing diagnosis, certainly a risk for bleeding. We're going to monitor urine output and bleeding, and we need to carefully monitor any changes because this can help prevent major complications that can happen. We want to encourage fluids. Increasing urine flow can help flush the blood and the chips and things from the bladder. Teach patients to avoid anything that can increase pressure in the abdomen, like constipation, lifting, straining, those kind of things, because they can certainly increase the risk for bleeding. And then certainly aspirin and NSAIDs, they should avoid those as they inhibit platelet function and again can increase the risk for bleeding. Another nursing diagnosis would be acute pain from bladder spasms. So we want to monitor for pain, irrigate the bladder as ordered, and this is to prevent clots and chips from clogging the catheter, which can cause, again, more pain if they're unable to empty the bladder. We're going to administer analgesics and antispasmodics for pain management, and then we want to teach some relaxation and deep breathing as well that might help with non-pharmacological ways to reduce pain. One would be urge urinary incontinence. And this could be related to poor sphincter control. We want to teach Kegel exercises, and this is to strengthen muscle tone. We can offer condom catheters or pads to keep them dry until incontinence can be controlled. We still want to encourage them to continue drinking fluids because this is important for healing and preventing urinary tract infections. Then we'll discuss prolonged incontinence. So we want them to discuss prolonged incontinence with their physician. They may have to learn to self-cath, or they may have to try other medications in order to help with the problems with incontinence. So risk for ineffective self-health management. Again, we want them for about 6 weeks to avoid heavy lifting, stairs, driving, any kind of strenuous exercise or straining or sexual activity. Again, heavy lifting or straining can disrupt the healing process and result in tissue damage or excessive bleeding. And then, as we talked about not too long ago, aspirin and NSAIDs affect platelet aggregation, and so, again, increased risk for bleeding. So one of the things that you'll commonly see after somebody's had prostate surgery is this bladder irrigation setup, and it's a Foley catheter basically that has an extra tube in it, and you can see here on the slide the extra tube right here. So this tube goes into the urethra and into the bladder. This one inflates the the end. And then this third one attaches to the fluids here, which will continuously irrigate the bladder. Effective therapeutic regimen or management. We want to teach the patient about catheter care. We want them to report signs and symptoms of urinary tract infections and report increase in any bleeding. We want to prevent UTIs, as these can be extremely dangerous and can actually cause death following genitourinary surgery in elderly patients. Anxiety related to sexual dysfunction. We really want to explain retrograde ejaculation, as this is common after prostate surgery, because part or all of the prostate is removed, and so there's a decreased amount of semen that is produced, and then part of the ejaculatory duct may also be removed, and what happens is the semen is pushed into the bladder, so there'll be little or no ejaculate that comes out. It's not dangerous. It doesn't cause any problems. It'll come out. The semen will come out when they pass urine. But what they need to know, that as long as there are no other problems present, they'll still be able to achieve erection and orgasm. There will just be a decreased or no ejaculation. So now we'll change gears and talk a little bit about prostate cancer. This is the most common cause or most common cancer among American men. Risk factors for prostate cancer are being over 65, high testosterone levels, high-fat diet, family history, and occupational exposures. It usually grows very slowly and often does not cause a major threat to health or life. There are many treatment options, and the prognosis is often very good. It spreads either through a local invasion, it can spread through the lymph system or vascular system as well, to metastasize to other areas. And it's staged and graded like all other types of cancer based on growth and the spread. So there are any early types of signs and symptoms, but later there can be urinary obstruction, hematuria, or urinary retention. And then in the advanced stages, you'll see things like bone pain, anemia, weakness, weight loss, and fatigue, and these are all related to metastasis and where it has actually traveled to. Complications that you'll see are difficulty with urinating, bladder or kidney infections, and also some erectile dysfunctions. Diagnosis is digital rectal exams. Certainly they can do blood draws for PSA or PAP. These, when they are elevated, indicate cancer. They may also do bone scans to see if it's metastasized to other places. They can do transurethral ultrasound with a biopsy, and that's what you're seeing here in this picture, where they will insert a scope through the urethra and then gather a specimen or tissue sample for pathology. So some of the interventions, early on you'll see testosterone suppressing medications like Lupron or Zoladex. In the later stages, they'll do surgical interventions where they'll do the TURP or the open prostatectomy, also radiation therapies. If there's metastases, you may see an orchiectomy or removal of the testes if they're affected. Estrogen types of therapy, chemotherapy, radiation, or conjunction of those, or a radical prostatectomy where the entire prostate gland is removed. So now we'll talk about penile disorders. First, Peyronie's disease, which may cause a painful erection or difficulty with penetration, and erectile dysfunction. And this is around fibrinous bands or scar tissue or plaques that are built up around the penis that when an erection is achieved, the penis can be, it could be painful, but it causes the penis to curve. Medications are tried first, but surgery may be needed to remove the plaques, or there can be injections used to break down scar tissue. Priapism, this is a prolonged painful erection, so an erection that's lasting more than 4 hours. And this is caused by spasms, which make it so that the blood cannot drain, and the penile tissue then is not getting oxygenation. So this can be a huge problem because there can be tissue damage if it is not fixed right away. So initially they'll try ice packs and other types of things, but then irrigation or drainage might need to happen as well. So phimosis, this will happen for uncircumcised individuals. So the uncircumcised foreskin becomes so tight that it cannot be retracted around the glans penis, and then there's schmegma that builds up underneath and becomes trapped, and that increases the risk for yeast and bacterial types of infections. They'll do antibiotic types of treatment, worm soaks, and certainly will try to get where they can retract the skin. Sometimes they'll have to do a small incision to help the foreskin be able to retract. If they're still unable to get the foreskin to retract, they may have to do a full circumcision. Prevention around this is through education and teaching boys who are uncircumcised from a very young age about proper cleaning techniques and how to properly pull back the foreskin and those kind of things to prevent this from happening. Paraphimosis is when the uncircumcised foreskin actually is pulled back and then not immediately replaced, and then it gets stuck in that forward position. And this can cause constriction of the dorsal veins, which can lead to edema and pain. So cancer of the penis, so this is found in men that are not circumcised or who have acquired HPV. Usually it is a squamous cell type of carcinoma, and this type of cancer actually can be spread to the sexual partner. Some therapeutic interventions include surgery, radiation, chemotherapy, or combinations of those things. Certainly, if too much tissue needs to be removed, penile reconstruction can be done. So, for testicular disorder, we'll talk about cryptorchidism, which is undescended testes that stay up inside the abdominal cavity. Usually they will descend by age 2, but if not, surgical intervention should be done to correct this problem because it can definitely lead to problems with infertility and other types of problems. Hydrocele, which is fluid in the scrotal sac, it really only needs treatment if there's discomfort or a threat to the blood supply because it's so big. So if it's so big that it's threatening the blood supply to the testicles, then that would need to happen. Varicocele, this is varicose veins of the scrotum, and this can be fixed with a surgical repair. Epididymitis is an inflammation or infection of the epididymis, and here they'll do some antibiotic therapy. They'll likely do testing for STDs or STIs as well, and do some prophylactic treatment for that. And then orchitis, or an inflammation of the testicles themselves, can be, it could be from inflammation or infection. It can be caused by trauma or infection, either from the epididymitis or from a urinary tract infection or sexually transmitted infection. This makes the testicles swollen and extremely painful. And what they do for this is bed rest and scrotal support, so meaning scrotal elevation, antibiotic therapy, and then medications for pain and fever. So testicular cancer, this is the most common cause of cancer of men between the ages of 15 and 34 in the United States. The etiology is really unknown. Some of the risk factors include family history, DES use by mother, Caucasian, high socioeconomical status, and cryptochytism. I can never say that word. I'm sorry. So prevention is through early detection. So here's where those testicular self-exams really become important to do on a regular basis. So signs and symptoms. Early on, there can be just a painless lump or swelling, and later on, as it metastasizes, you'll have different types of symptomology depending on where the metastasis goes to. So diagnosis through ultrasound, chest x-rays looking for metastasis to the lungs, because that is one of the places that this cancer likes to go. Blood for different types of tumor markers or biopsies to gather samples and see if they are cancerous. And then staging again is the same with all other forms of cancer based on growth and if it has spread anywhere. So interventions include surgery, removal of the cancerous testicle. They'll also remove the spermatic cord and local lymph nodes at that time, radiation and chemotherapy, or a combination thereof. If it is detected and treated early in the beginning stages, the chances for a complete recovery are actually very good. So nursing care, we're going to teach testicular self-examination, and we talked about that in the previous lecture. We definitely want to provide emotional support. Remember we talked about in the cancer lecture, even if you're diagnosed with a form of cancer that is very curable, it is a really scary thing to hear. So we definitely want to provide support there. We want to discuss sperm bank deposits because if the patient wants to have children, this should be done before the treatment begins. And then we can offer information on different cancer support groups. So vasectomy, this is an interruption in the vas deferens, which prevents the sperm from reaching the outside of the body. So this provides a permanent type of birth control on the male side of things. The surgery itself only takes about 15 to 30 minutes and is usually done in a doctor's office. It is not effective for about 3 months following the surgery, so that's really important to keep in mind. Reversal is possible through microsurgery called a vasovasectomy. If this cannot reconnect the vas deferens, they may connect it to the epididymis. It's important to keep in mind that it's definitely more successful, the reversal surgery is more successful if the sooner it's done after the initial surgery or initial vasectomy. So it's possible, but certainly more successful earlier on. So erectile dysfunction, this is problem obtaining or maintaining an erection and can happen at any age. Affects not only the male, but his partner as well, so that's important to kind of keep in mind as we go through this. The cause can be psychological or physical in nature. Most men experience a temporary erection problem at some point in their life. Some of the common causes psychosocially are stress and illness, fatigue, alcohol or drugs. And then physically, circulation, inadequate blood supply coming into the penis. For nerve pathways, there are many of these that must be intact for a usable erection. There can also be a problem with hormone balance, with either decreased testosterone or decreased luteinizing hormone increase in prolactin, which in large amounts can block testosterone. And then also there could be problems with the limbic system, which is the center of the brain that affects how we feel emotionally and definitely works to stimulate the desire for sex. So diagnosis, medical history, we want to know medical history, surgical history, any medications that they may be taking, injuries, if they have a history of substance abuse or currently using substance abuse. We want to know about their lifestyle, their sexual history, any types of hormonal imbalances, certainly evaluations of circulation, because as we talked before, that can definitely affect how they're able to achieve an erection. And then psychosocial types of evaluations to see if there's high stress or illness or those kind of things. And are there any surgeries or interventions that may have decreased circulation or nerve impulses? So therapeutic interventions, we may need to do some medication changes if they are currently taking medications that can cause problems with erectile dysfunction. They can start taking oral medications. The ones here are Cialis, Viagra, and Levitra. They may need hormone replacement therapy or hormone therapy to get their hormone levels back into whack. There are also some herbal remedies that can be used, like yohimbe, DHEA, ginseng, or ginkgo biloba. Other medications, there are injectables that can be injected directly into the penis. They're pretty much painless, and they can produce natural types of erections. And then there's transurethral types of suppositories that can be inserted into the urethra, which also can cause natural type of erections fairly quickly. Just need to be careful because, again, these ones, if we're causing an erection to happen, we can swing that pendulum to the other side and end up with problems with priapism. And you can have those same problems with other medications mentioned, too, with the Cialis, Viagra, and Levitra. So need to talk to patients that are using these modalities about priapism as well. Devices, so there are external types of suction devices that can be placed on the penis, which draw the blood up into the penis, and then once the erection is achieved, the device can be removed, and then the patient would be able to have intercourse after that. And then there's certainly surgery to restore vascularity to the penis, and also implants can be done. This can be a solid or fluid-filled type of chamber that is surgically placed into the penis, and then there are some that are inflatable and some that are non-inflatable, but basically the implant will help or will create erection. Sorry. And then again, vascular surgery can be things like bypass grafts that can be done to increase blood flow to the penis, or it can be used to go around a blockage. So nursinosis, here, risk for ineffective self-health management related to knowledge deficit of the cause and treatment of sexual dysfunction. So we'll talk a little bit about infertility, and it can be caused by endocrine dysfunction or autonomic nerve system function, or structures within the system not functioning properly. It can be considered pre-testicular or endocrine, so before the testicles, problems with hormones, those kind of things. Testicular, where there is either like a varicocele that causes the problem, or it could be idiopathic or congenital types of problems. Anything really that can cause problems with the actual sperm production. And then it could be post-testicular, so a surgery. It could be either vasectomy or pelvic lymph node removals or other types of surgeries that may affect it, or like bladder neck reconstruction, or any surgery that causes the retrograde ejaculation or a decrease in the amount of ejaculate. So with diagnosis for infertility, they look at sexual practices, so frequency and timing of intercourse, problems with premature ejaculation, lifestyle practices, so use of hot tubs, saunas, does the person wear tight jeans? They look at dietary types of things with caffeine, nicotine, alcohol, or marijuana use. Certainly occupation, is there increased stress or prolonged sitting? Medical surgical history, so again, have they had a surgery like vasectomy or those other surgeries that cause problems with retrograde ejaculation? Have they had any sexually transmitted infections? Do they have any endocrine problems? Have they had cancer or chemotherapy? That's just some of the information that you may gather. And then for physical examination, they'll look at normal growth, hair distribution, any type of evidence of the varicocele or hydrocele. And then semen analysis can be done as well, and that's just looking for, do they have the right amount and type of healthy sperm? Do they have any types of infection? They may also do some genetic testing, ultrasound to look at structures, or hormone types of testing as well. So therapeutic interventions, changes in lifestyle practices. So it just may be as simple as changing sexual practices, meaning the people that are trying to have a baby are not actually having intercourse during the time when the woman is fertile. And so that could be a simple fix. But certainly there can be surgery that needs to happen to correct any problems like the varicoceles or other types of obstruction. And then if none of these things are working, there are other options like in vitro types of procedures that can be done. And then adoption is always an option if all of these other things are not working. So please post any questions that you may have in the questions section on the discussion forum. There are no required postings or anything of that nature for this lecture. However, I would appreciate it if you do have questions to post them in the question forum, so that way other folks may be able to see the questions you're asking and get those answers as well. You can always email me or just ask me if you have any questions if you don't feel comfortable posting in the forum. Thanks, and we'll talk again soon.